Hi, it's Dr. Centeno, and thanks for joining me today. My voice is a little bit impacted, COVID negative, but have a little cold. I guess cold still exists these days. And so yeah, you may notice my voice is a little bit off today. I may cough once or twice, but so thanks again for joining us here today. We've got an interesting topic. We're going to talk about these complex relationships between how your upper neck ligaments and muscles basically jack into the covering of your brain and spinal cord, called the dura. And we'll talk about the myodural bridge. We'll talk about some new research on how complex all of that is. And then we'll take questions either about this topic or pretty much any topic you're interested in. So let me go ahead and share my screen and we'll get ready to do all of that. Okay, the complex relationships of how your upper neck muscles and ligaments are jacked directly into the covering of your brain. That's also called the dura. So we'll be talking about all of that today. And again, usual format is I'll start with something like this, and you can ask questions about this once I'm done. You can ask questions about pretty much anything. Again, I've got a little cold today, so you may hear me my voice is a little off. So your neck is filled with lots and lots of ligaments, and this is only some of them shown here. And the back part, in addition to this posterior lennox-occipital membrane, which you'll see based on the new stuff I'm going to show you, is kind of part and parcel with the dura, or the covering of the back of the brain there, but one slides against the other. But in addition to that, you've got ligaments up in here, the nuchal ligaments, and you've got ligaments going here, vertebral dural ligaments. And these ligaments, vertebral dural ligaments, jack into the dura as well. And then there's muscles that come in here and at multiple places jack into the dura too. And this is the very simple diagram that I drew maybe 2 years ago, something like that, where you see these upper neck muscles jacking directly into the dura, or the covering of the spinal cord and brainstem, called the myodural bridge. Now, that's pretty good in that it shows conceptually what's happening. But more interestingly is a new research paper that just came out on how complex this really is. And so this is a team of anatomists, and Frank Scully, I've come to learn, is also a chiropractor who's an anatomist. And this paper was just published on May 30th, 2022. And it includes some great diagrams about how complex these structures are. So this is the diagram here. Off to the right, you can see that we're talking about the upper neck here, which is this region. But when it comes to all of these parts and pieces, there's a lot going on. You've got multiple different myodural bridges here, meaning connections between muscles and the dura, or the covering of the spinal cord. You've got other myodural bridges that are occurring between various ligaments and the covering of the spinal cord. You've got parts and pieces that are coming off of muscles that are jacking into the spinal cord, including various different muscle groups: rectus capitis posterior major, rectus capitis posterior minor, etc. So an awful lot is going on here. And what seems to be the general theme is lots and lots of different ways for your body to exert pulling pressure on the dura, or the covering of the spinal cord. So your body can pull it back like that. And so you might ask yourself, why would your body want to do that? And why all these complex connections? Well, when you bring your head back, the dura, which is shown right here, can buckle into the area of the spinal canal. Now, if you've got the ability to have muscles there that pull that back, like in this right image, then that area stays open. And if you've got, let's say, something like a Chiari malformation down here, that's going to be a bigger deal. Or if you've got less room in this area, that's going to be a bigger deal if those muscles don't act to keep that area open, like you're seeing in this one off on the left. Also, there's a theory, and this has not really been shown as well because it's harder to study, that these muscles and connections are keeping all of this open when you rotate your head as well. And what's the reason for keeping this area clear? You've got cerebrospinal fluid that's being pumped through here, going kind of both directions. In addition to that, you wouldn't really want to bang into things like the lower part of the brainstem or the lower part of the cerebellum when you brought your head and neck back. Now, because of all of this, we've been injecting many of these structures now for a good amount of time. You can inject them under ultrasound guidance, but it's not all that accurate. You can get better accuracy if you use X-ray guidance plus, in addition to the X-ray guidance, plus injecting radiographic contrast. So this is the rectus capitis posterior minor muscle there, and you can see it's starting up in the skull and it's jacking directly into the dura right there. So we've perfected doing this now. It's taken a while to develop these techniques because they didn't exist. In fact, as of 10 years ago, no one knew this bridge or myodural bridge existed. So now let's go to some questions. I'll stop the sharing. Again, my voice is a little bit off today because I've got a little bit of a cold, COVID negative, but cold. So colds still happen. So let me take some questions here. Regenexx, somebody advanced by Harry Winston. Are your muscles involved in CCI or just ligaments? And can you treat the muscles or only the ligaments? So Harry, we can treat both the muscles and the ligaments. So it doesn't have to be one or the other. The muscles, eventually, you're also going to have to get stronger on your own. But as I was just talking about, we do inject those muscle tendons quite a bit now. Mega May can't hear. Let's see. Do I have a... let's see. Let me go ahead and do a sound check here. Make sure everyone is hearing me. Okay, great. Okay. So let's see. Going on here. It's been advanced by Caroline Harvey. Is it safe to exercise your upper neck muscles, or would that be problematic force in the brain since they're connected? I think you'd want to make sure that you talk to your doctor about that and get his or her specific opinion to make sure it's safe. Now, when it comes to our PICL patients, we generally don't recommend strengthening those muscles until we stabilize things from a ligament standpoint. So that's on a case-by-case basis. Shanze, high Dr. Centeno, in order to keep the area open by muscles, did you inject into the muscles tendons directly for them to heal and activate during cervical extension, or injections achieved? This would be the C0 to 2 joints area. No, direct injection to the muscle tendon, because these are muscle tendons like any other, and they can get tendinopathic, which means the muscles don't work when that happens. Bonnie, what's the volume injection for PRP? Bonnie, that just depends on what it is we're injecting. Different structures require different volumes. So maybe if you had a specific question about which structures, I could tell you what kind of the average injection volumes would be for that structure. Megan, can you do legal expert witness about this topic? I had bad traction injury and patient Dr. Schultz. Megan, you'd want to talk to Dr. Schultz, who'd be your treating doctor, if there's any request for medical legal opinions or anything like that. So that's something you'd want to talk to Dr. Schultz about. Bonnie, after PRP injections, do you have a program for strengthening severely weak and degenerated neck muscle after being prolonged bedridden? Yes, we do have one, and that's online. And but again, we want to make sure that the ligaments are strong enough to support that first. So that has to be cleared with your doctor. Stacy, why would base of skull hurt near the ears and at the center base? That it upper traps, but rest of the neck doesn't hurt unless laid down, which part it all hurts. Well, the base of the skull near the ears would usually be the 0-1 joints or the lesser occipital nerves. The center base would be these muscles we're talking about here. And then the upper traps frequently get involved because there's no ability for the head on the neck to stabilize itself. So the upper traps have to jump in there. Shanze, do you do ultrasound imaging to see muscle or tendon tears? How is it assessed if one is experiencing ligament laxity or muscle tendon dysfunction in the CCJ area? Shanze, we can do ultrasound, or we can look on MRI. But seeing small muscle or tendon tears in these really small muscles is usually something that's difficult to do. Shanze, for 60 cc or 120 cc blood draw, how much cc concentrated PRP and PPP would it yield? Well, you normally take it in half, and then you divide by the concentration factor. So 120 cc blood draw would get you 60 cc's of starting material. And then from there, 60 cc's. So if you had a 10x, that would yield 6 cc's. If you had a 20x, it would yield 3 cc's. Give or take. It all depends on how concentrated all of this is. Shanze, have you seen a spinal accessory nerve injury in a case where left SCM doesn't activate and feels like jelly? We've certainly seen issues with the spinal accessory nerve, which would be the innervation for the SCM, but not quite sure what you mean as far as an injury where the SCM feels like jelly. Megan, can you share the study? Yeah, Megan, I'm not quite sure which study. If you're talking about all these connections, that study should be in this video once we get the video all done. So if you can reach out to our Facebook page, actually that should post there right after this. If you just go back to the video, you'll see that study. Bonnie, I sent a detailed history of my injury and symptoms to current, along with an MRI report, summaries on my DMX to the email you provided previously, and we'll see you in mid-July. Is there anything else that might be helpful to send? Let's see. So yeah, so we need not MRI report summaries, but we need the actual films. I don't really read radiologist summaries unless there's a specific reason to, i.e. we're looking for something rare. So we would need the actual MRI images as well as the DMX images, and then obviously any medical records that you have for things that you've tried, patients that or doctors that you've seen, things like that. Shanze, thanks, Dr. Centeno, for the nerve injury. If there was trauma to the neck from the side around C2. Curious if that could cause or that could damage the nerve so the muscle doesn't activate. Yeah, Shanze, we need to take a look at that clinically to see if that looks like a likely diagnosis where the spinal accessory nerve has been damaged and therefore the sternocleidomastoid doesn't work. Sabina, how important you think is the role of realigning the entire spine is addressing any muscle imbalance in the body? Would doing that also be crucial to protect those ligaments we are injecting? I'm doing PRI and Egoscue. Sabina, getting good postural symmetry, front, back, left, right, is a great idea. So definitely would encourage you working more through Egoscue. Now, it may not solve the instability issue, but it may help take some of the weight and force off the upper cervical spine. So I would definitely encourage you to continue doing that. Other questions I can answer, guys? Looks like we have run out of questions for the time being here. Here we go. Bonnie, if a chiropractor indicated C1 is rotated, is an adjustment needed prior to PRP or PICL? Yeah, Bonnie, if you've been working with a qualified NUCA or AO chiropractor and that really helps, we would definitely want you to continue that work while you do any type of injection procedure for your upper neck. Any closer to knowing where to inject during PICL for trigeminal nerve pain? Yes, Stacy, there's some lectures I'm working on for that issue, but we definitely have treated trigeminal nerve pain and have treated that where V2 comes out. So that's something to consider. There's also some anatomy that shows that when you have big C1, C2 overhang side to side, the trigeminal nucleus is probably getting banged into, and that's probably not helping any of this. But yes, we have treated V2 at the fossa where V2 comes out of using X-ray guided procedure. Yeah, Bonnie, in general, we recommend NUCA or AO chiropractors. So if you just go do an online search, you should be able to find one in your area. Adina, do you believe orthodontic treatment can alter occlusion and influence upper cervical instability? How about removal of wisdom teeth? Well, Adina, I normally see the opposite, where we see upper cervical instability and then the jaw and TMJ get overloaded. And so consequently, this usually causes that. As far as being able to fix CCI through TMJ type treatment or other type of jaw or tooth treatment, I've never seen that work to date and would be surprised if it did. So normally, again, patients with upper cervical problems start using the anterior muscles in their face. Those muscles of mastication are the jaw muscles or all these strap muscles up front to help stabilize the head on the neck. And eventually all of that develops a life of its own. People go in to get their TMJ treated, and frequently they're told they're two separate things. But I've never seen anyone use orthodontic treatment to get rid of upper cervical instability, nor would it make sense to me that it would work. But hey, always open to new interesting things. Other questions I can answer, guys? Okay, so to just review here today, we were talking specifically about all the crazy connections between ligaments and muscles in your upper cervical spine and the covering of the brain and spinal cord, and how we've changed our treatment through the years to inject some of these ligaments and muscles. But it's amazing how complex the system is, and the system seems to be designed to keep the spinal canal open when you bring your head back or you rotate your head. So thanks so much today, guys, for all the great questions. I appreciate it. We're entering a little bit early today. I just saw another question come through, so let me get that one. Nick, I do shoulder presses or side lateral raises, even with very light weights. I get a terrible headache, along with pain on the left side of my posterior neck, where my skull begins. Would this respond to PRP? Nick, certainly possible that it would. We would just need to know more about which structures there are causing the headaches. But those are certainly the kind of things that we treat quite a bit. And then some cold advice and some thank yous there. Okay, sounds great, guys. I will see you. I won't see you this coming Friday because I am going to be down in Fort Lauderdale lecturing on some of this stuff and at a medical conference. So, but I will be here a week from today. So I will see you then. Thank you.